Hello, my name is Hector, Dr. Colón-Rivera. I'm a psychiatrist, and today I'm going to talk to you guys about the imperative of diversity and health equity in mental health and substance use disorder treatments in healthcare system. And I'm going to be focusing in health systems in the United States. I'm a member and co-founder of CreearConSalud, which is a nonprofit organization that develop mental health education projects in Puerto Rico and some Latinx communities in the United States. Our work consists of providing free workshops to communities, organization leaders, and we work usually with underserved communities to help them to better prepare to address their mental health needs. I'm also the medical director for APM, a nonprofit organization located. Today, objective, I'm going to concentrate on three objectives. We're going to define diversity and health equity. We're going to discuss the importance of racial and ethnic diversity of the healthcare workforce, and also some of the benefits of advancing cultural competency and increasing access to high quality healthcare services, not only for the patient, but also for the workforce. Um, and last, learn solutions to reduce the healthcare diversity and health equity gaps. And I know diversity and health equity is defined in different ways by different people. But health starts in our homes, schools, workplaces, neighborhood, and community. We know that taking care of ourselves by eating well and staying active, not smoking, not drinking, and all getting all that recommended immunization and screen tests will influence our health, personal health in general. But our health is also influenced and determined by a part of the access, right, to social and economic opportunities, and also some resources that sometimes are out of our control, like support available in our homes and neighborhood and communities, and the quality of our schooling and safety of our places and public places is really important. So how all this interface to describe the health inequities that we live in nowadays. So health inequities are defined by the the World Health Organization as systemic difference in health status of different population groups. Again, I work for two nonprofits, mainly uh, focusing on Hispanic communities, but we also serve African Americans and Caucasians as well. Also, our staff is multicultural, and we do not uh, define race or we have any boundaries with race or ethnicities. We see everyone that cross that door for us to get services, and we help them equally. Um, the social determinants of health are conditions in which people are born, grow, live, work, and age. So they are defined by society, some of them, and by the economic status of our patients or staff. Uh, this situation are shaped by the distribution of money, power, and resources at a global level, also national and local levels. So I'm in Pennsylvania, I'm in Philadelphia. So in Philadelphia, every county budget is different, and same with different states. And we compare Pennsylvania with Delaware or Jersey, our neighbor states. And social determinants of health are mostly responsible for health inequities, the unfairness of differences in the health status seen within between community. So we put fairness apart for that for a moment. We still have at least four practical reasons that we can put forward of attaining greater diversity in the health system workforce. We need to advance cultural competency, and that's really important for me. Well, cultural competency is not only right, and when we talk about cultural competency, it's not only talking the language or the second language, the third language. It's understanding what's going on in in that neighborhood, understanding what's going on in that family that you're serving. Also, increasing access to high quality healthcare services, and that services that can be personalized and a mode for that person in front of you. We need to strengthen the medical research agenda. And we know minorities and people that we treat does not they don't participate in treatment due to either poor education, poor marketing for our part, also fear of getting in research studies, or fear of being punished by school or their workplaces for missing job days or school days. So we're not doing a great job understanding some of the cultural components to our patient due to lack of research in that community. Um, we need to ensure optimal management of the healthcare system. I mean, when we talk about budgeting and things like that, we need to understand what goes on those numbers, right? So you need someone, leaders that understand not only the clinical part, but also the business part, the the budgeting part. And cultural competency or competence. The term cultural competence denotes the knowledge, skills, attitudes, and behavior required of a practitioner to provide optimal healthcare services. At the end of the day, what it matters is that you are providing the service that that person needs. Not providing the services to everyone equal, right? Because that doesn't equal equity. Um, and this example, right? If you don't get the same sunlight to all the plants, the sunlight that they need, right, is not gonna work for them. If you get the same sunlight to everyone, and some of the plants will grow, some of the other plants will not grow, some of the plants will get burned or die, right? And you're gonna have a differentiated community, a community that is not functional. Same here, right? We have three different people with three different needs. If you don't give what they need, they will not be able to get to the health level that you need. In this case, they are unable to watch the baseball game. If we're giving three boxes or one box to every individual, they might not need, some of them might need just one or not box at all. Some of them might need one box versus two boxes. So we're giving what they need, not what we feel is equal. And of course, cultural competence is not an old, I mean, it has been around for a few years now, but it was not until 1999 when the Surgeon General released a mental health report. And that's where we describe that this report finally acknowledged that not all Americans, especially minorities, receive equal mental health treatment, right? And when I talk about mental health, I'm an addiction physician. I'm a board certified addiction medicine, addiction psychiatry. I include substance use disorder in physical health and mental health treatment. And then it was not until 2001 that we defined and published one clear message about culture, like cultural counts, and that's why we start working in a cultural, biopsychosocial, cultural assessment, right? So we include culture in our assessment now. And many research studies have shown that because of lack of cultural competence, people of color may not seek service in the formal system. People of color, meaning minorities, including African Americans, Asians, and Hispanics, right? But also people of different backgrounds don't look for services, formal system services. I mean, people without home or homeless people, low education, or without a job or income. Um, they cannot access treatment. They drop out of care more often. Attrition rates are higher, are also misdiagnosed. I mean, there is good data behind people of color or Hispanic or African Americans are diagnosed with more psychotic disorders or more bipolar disorders because of cultural components and the way they present. Um, and they usually seek care only when their illness are in advanced stages. So we see more African Americans, more Hispanic or minorities seeing and looking for treatment when they are in advanced stages of cancer or when they already have diabetes. So there is not good prevention health on these communities. And the determinants of health are multiple, right? We talk about behavior, but there's also the biology part of it, the environment versus the biology, and what's going on in environment. I mean, it could be social, could be physical, could be in access to care, what kind of job you have. We know minority works more in in farmer construction. Also, climate change has some better and bigger impact in minorities community and affect the cultural representation of our patients. I think this is worth saying. The Healthy People 2000 approach to social determinants of health, they divided in pretty easy structures, 5 groups: economic stability, education, social and community context, health and health care, and neighborhood and building environment. So they divided and they developed a Healthy People 2000, 2020 study and a good plan, a good structure to invite you guys to search it and read it. It's a good information there. And of course, health determinants start early life. If we don't start educating our patients, our staff in from the beginning, right? We're not gonna get the outcomes we want. Um, so generally, increasing general level of education provide equally opportunity, right? And we're talking about equity. No, when we talk about equal opportunity to access to education, relationship with the parent and the child, protect our minorities and from discrimination, social isolation, and public health policies. This is really important. Advocacy is really important for our patient. They need a voice and also an action. Um, so what we do to the system diversity to fill those gaps that we have, where do we begin? Well, of course, and we talk a little bit about the Health 2020 and some of the structure they present, but also how we should start from early. And a great example is, I mean, right now we're living in a pandemic that the pandemic has exposed and further exacerbated the fracture in our healthcare and social delivery system. And we have seen all the fails and the gaps and the cracks that our system had. I mean, it's a great beginning to go back and restructure our system. There has never been a more urgent time to start doing an action plan, a strategic framework to address adverse social risk factors that have been exacerbated by COVID-19 or SARS-2 pandemic. Also has contributed enormously to health inequalities and during the pandemic. I mean, we have seen how people from minorities have been most affected. They're dying twice to maybe sometimes 3 times a higher rate than their white or Caucasian counterparts or educated patients, because our patients they don't have, most of them they work in really rough environments. Also, they don't have insurance. They wait to until the last day to look for health care. Also, we didn't do a good job, us, right, as physicians, as policy making and healthcare facilitators, in terms of educating the community. I mean, most of the we're talking about cultural and language, right? We did not produce the education needed at first about no contact or contact precautions and isolating yourself and physical isolation. I mean, that was only in English. Most of the White House briefing were in English. Most only education part was coming from the CDC, and that was an automated trans- translation device. So it was not some of the things that they presented first. It was kind of broken Spanish, so it was making no sense. So I think this is a great opportunity, and that we can achieve if we work all together. And when we talk about all together, we need to take all those part of our society, such as transportation, housing, agricultural, commerce, right, e-commerce, technology, education, in addition to the medical care, and become broadly and deeply engaged in promoting health, but all together. A great example that we have a good success rate was when we worked together for the smoking cessation part. One of the most effective means of reducing the prevalence of tobacco was increasing federal and state excise tax rates. And I don't know if you remember this, but a 10% increase in the price of the cigarettes led to a 4% reduction in the demand for cigarettes. And this is amazing. I mean, it was a massive public health campaign that all states, most of the states were part of it, but also the doctors, also the patients, also society, also restaurant, also the churches, also transportation. We work as a society, and then I mean, people still smoking, right? But people's not smoking at the rate that we're smoking. We have been able to decrease heart conditions and treat other people. I mean, a lot of people stop smoking, and smoking is not sexy anymore. It's not attractive anymore, and we did that working all together. Um, so assessment and introduction to treatment. I mean, clinical intervention and management need a team-based approach. We need educational strategies and regulatory efforts, economic approaches, creation of comprehensive program. All this need the same approach. Let's take a look to the health system in terms of substance use disorder. We have a long misrepresented nature with the opioid substance use disorder, right? We have a massive epidemic that's still happening. It was happening before the pandemic of COVID-19. It's happening now today, 2020, and it's gonna happen. It's gonna stay after the pandemic. It's an epidemic within the pandemic. People still dying from opioid use uh, and overdoses, and and we have this system that includes everything that you see on my slides: primary care, behavioral health, dental care, counseling services, mental health, psych treatment. Before, we were unable to use technology to treat substance disorder. Now the pandemic have opened the door for the telehealth and prescription, and Sam said decrease the regulation to do this, expanding some the access. Of course, didn't I mean, telehealth is not for everyone, but at least you have an interest in opening to maybe increasing access, maybe creating some equity for our patients. But of course, there's a hierarchy of intervention that we need to talk about and mention, right? Applying design thinking and precocial ethnicity and principles is really important. You need to know long-term effectiveness of your treatment. You need to know who your partners are. You need to know what is effective. Uh, we can do death prevention. We can do harm reduction. We can do medication, but evidence-based treatment, right? But you need to have structure and a pyramid of situation to be able to do this. And part of the inequities of the health system does not allow practitioners or clinics or something the state or the federal government to create programs and implement these programs. Yes, it looks great, some programs in paper, but once you implement it in minorities or in places that there's a huge inequality or gaps, that implementation fail. A great example is, I mean, the situation in Puerto Rico. I'm from Puerto Rico. I know Puerto Rico pretty well. I have a nonprofit. I work for a nonprofit in Puerto Rico as well, and we confounded a nonprofit organization in Puerto Rico to help with that, with those gaps in the system. Um, Once we implement the same SAMHSA project or the same regular HHS project, we translate that from, for example, Florida to Puerto Rico, we that's not going to happen, right? I mean, we have a cultural situation, we have a language different, we have a budget in different. Medicare budget does not equal the ones. I mean, works in different ways. The gap is huge in Puerto Rico, so getting the same project to one state to the next state to the next state without counting cultural competency or diversity or the inequalities that what is the poor rate, what is the coverage for insurance, what is the budgeting, what's the structure, what is the clinics, how many patients you can see, how many doctors are certified to prescribe certain medication like buprenorphine, how many have a waiver. All that information need to play out in that implementation of this project. And if you don't have that information, you don't that if you don't do that research, your assessment and implementation will fail. A little bit about what we do at APM. I mean, we are community mental health. Who we are, our mission is to help families achieve their greatest potential. And when I say families, we see kids, we see adolescents, we see uh, adults and patients over 65 plus. And we do Medicare, we do Medicaid, and private insurance. Our vision is to create healthy communities, and we're all family and self um, centered, right? We are patient centered treatment, and we prioritize our patients. So APM theories, the change is we treat our patient's family, and the family, is part of our neighbor and part of the city. So this is the theory of a change, neighborhood, family, and shell. That's why we have a Department of Foster Home, Adoption, family. We have a workplace development. We also have education, supportive housing, affordable housing, and neighborhood. We have comprehensive planners. We have some literature development, civic engagement, and we're working on some ways of working with small businesses and commercial development as well. Um, so, who is the community mental health? Again, I mean, I think is the goal of the community mental health is to be part of a neighborhood, be part of the city. We need to be functional, not only psychological but also social, environmentally, and biological. And all this plays, you know, has a place in the functionality of the community, also in the person. So once you create some functionality in one person, one member of the family, we're going to start to work on the family. And once you have a family that's functional, you're going to have a neighborhood that's functional, and now the city, and now a nation. And we're seeing that. At least I want you guys to see what's going on with the pandemic and how this is an opportunity for us, for the people, for the government to kind of fill those gaps that we have been struggling with. And for that, we need partners. We need to consider best practice of assessment for any type of practices, more patient-centered assessment. We need to focus back on the baseline functional impairments. I mean, what was causing the impairment? We need to review ourselves. What caused the crash in our stock market, or our medical services, or why we didn't have enough PPEs for our first liners. I mean, that's a system issue, a system problem, a system gap that we need to review. We need to use valid behavioral health measures to support making a clinical decision. We cannot make the clinical decisions out of nowhere without a evidence-based treatment. That's why we need research, and you need that to make a good diagnosis instead of diagnosing people. And misdiagnosing someone and starting someone on that medication will create other issues, chronic medical issues. And once you have a chronic medical issues, people stop working, and that destroys the economy. Once you have a bad economy, you are affecting the nation, you're affecting the city, you're affecting your neighborhood. So everything is intercorrelated. And of course, baseline assessment and prevention is really important. Some conclusion and recommendation: ensure that you're focusing on the community at greater risk. If that absorb a big part of our economy. Also, if you don't have a functional family or a functional individual, that would affect neighborhoods and cities. We need to take care of the inequalities and create some equity in our health system, both for mental health, physical health, but also, I mean, substance use disorders. As I said, I include that in mental health disorders. So we need to increase our capacity of the prevention workforce to identify and address disparities. Of course, that's really important. We should be preventing and not fixing someone else's problems on your problems. So prevention should be first. We don't do a good job doing that, and I feel that's part of the inequalities that we are and the gaps that we have in our health system. We need to standardize and collect data to better identify and address disparities. And I think what we're doing with the pandemic and maybe creating data, the data we're going to get from this situation, I think will help us to develop better structures in the future. Quality of healthcare is enormous. I think we have seen that those of you guys are a doctor and been using telehealth and been seeing a different and a decrease in drop rates. So I hope in some capacity we can stay maybe in a hybrid system that we can do telehealth and also face-to-face. There's still a lot of value in face-to-face appointments and scheduling. So I think the future it will be a hybrid of those two things. And when we talk about access to treatment, I mean that's a big part to access to treatment. But also we identify that people have no access to transportation. They don't have access to telephones, smartphones, the technology. That's something we just take for granted, and we need to take care of that access to quality of healthcare, and support research to identify effective ways of eliminating the health disparity. Research is really important, and I don't think we have enough research in this nation, and we should do a better job on that. Some of my reference here, my name is Dr. Colón-Rivera. Please, you can email me at Hector Colón-Rivera MD at Gmail. Another email of mine is hector.colon-rivera at apm.phila, as Philadelphia, phila.org. You can email me with questions and anything that you want to collaborate, research projects or presentations, things like that. You can, of course, contact me. So it's been a pleasure. Thank you, guys. And if you have any questions, this is the moment.